We're having a panel now, and the folks, if you would come up, we would like to start that panel. Also, Tim Duvlantis will join us from Mayo, and Mobeen Rathore from University of Florida Health. Is that right, Mobeen? The name has been changed recently, so I'm fumbling just a touch with that. And Ron and Michael, I think you all are moderating this session.
So, Ron, thank you for that wonderful talk. And, you know, you can see kind of force of will, but you can also see a very clear methodology behind this, and also building an infrastructure across an organization. So we're privileged to have you all. And I think what I'd like to do is actually start by asking a simple question. Of the work you've been involved in, why don't we just kind of start to the right of Ron here, and could you take a few minutes and share with us the work you've been doing and one or two things that you're actually quite proud of and have been successful at?
Thank you. My name is Michael Spiegel, and I'm Chief Operating Officer for Brooks Rehabilitation here in Jacksonville. To answer that question, the work that we've been doing and the things that we're most proud of, I would categorize it in two areas. One is Brooks Rehabilitation is in the area of post-acute care. So it's inpatient rehab, skilled nursing, home care, the things that tend to be more separated from acute care hospitals and from physician involvement and engagement. And I would say probably the most important thing we've done in the last year is beginning to partner more with physicians from the various referring hospitals to provide and augment the care that we provide within our settings. So, historically, post-acute care tends to be disengaged, if you will, from many of the referring physicians and what goes on in the acute care hospitals. So I would say that's probably the thing that I think has been one of the proudest achievements in the last year, and the things that we have on our plate of more engagement with physicians being in our settings. And then for us being in post-acute care, which is the place where many patients are readmitted back to acute care, is a lot of the effort and attention that we've done in being able to reduce that, and a number of the processes and energy we've put to that, and some of the good results we've gotten.
So I think at UF Health, that's the new name, I think we have been focused a lot on improving quality of care. We have a very unique situation because we are outpatient and inpatient services. One of the initiatives that was taken, and Dr. Shah left primarily by her group, was to get more organized and get involved with NCQA, the National Committee on Quality Assurance. And we have a network of, I believe, 21 clinics, and we got a level 3 recognition for those clinics, which was really a feather in our cap. But that was the end result of a lot of effort towards improving access to care to the patients, their access to their information for their medications, their records, and making it easier for the patients, not only when they are out of the hospital and getting their routine care, but also once they leave the hospital, that handoff. Because we have a lot of residents, I believe, and Connie can probably correct me, about 110 new residents approximately join every year. We have to deal with a whole new group of physicians who are at very early stage of their careers. And so we have worked very focused on trying to inculcate in them that improved quality that we so much value. And part of this improvement in those quality factors is coming really from the highest level of our UF Health. Our Senior Vice President, Dr. Guzik, is very focused on that, and at our leadership in our institution. So I think we are focusing on multiple aspects of it, both on inpatient and outpatient, training and educating our workforce, which also has many challenges for us, but I think we are starting to see a slight it's a very large ship that moves rather slowly sometimes. A slight shift in the culture where it is okay to come forward if there's an issue and be able to say, as somebody said this morning, that there's something not right here. So I think we are working towards that.
Well, first I want to thank the community for being so receptive to the Navy. We're very glad to be a part of this community. I've been in the Navy for a long time, and I can tell you that I've never been stationed anywhere where I've felt more a part of the community than I do here in Jacksonville and Northeast Florida. So I just want to say that firsthand. I can tell you, in listening to Dr. Paulus, no one feels a greater sense of urgency than someone who has the privilege to lead as a commanding officer or CEO of a military facility when you have only 2 years. And then they're going to give you another set of orders and tell you to go. So you're right, trying to create a sense of urgency is sometimes difficult in our culture, the military culture. We feel that sense of urgency when we go to war and we know we have a mission to meet. But when you have a staff turnover of about 40% every year, and that's changing and the leadership changes, that presents a different challenge. But some of the initiatives that we've worked on, we really have to pay close attention to the mental health status of our patients in the military, particularly because of what they've endured for the past 10 years. And we have stood up a directorate just for mental health. And we are looking and working in those various programs for substance abuse and also TBI. And we are also maturing our medical homes. And so we're starting to see improved access to care. We're starting to actually have unbooked appointments during the day, which we've never had before. And we're starting to see our ED utilization go down. All of the things that the Surgeon General touched on today. So I think we have, in the past year, and I've been on board the command for a year now, and so I think we are seeing things move in the right direction, and we must continue, to keep our patients first and foremost. And the thing that we all have in common here today is the fact that we all strive to provide the safest, most effective care for those entrusted to us. So I appreciate this opportunity. Thanks.
Thank you. Absolutely.
My name is John Wilbanks. I'm the Chief Operating Officer of Baptist Health. I'd make one observation is that our Navy attendees are far more persevering than your colleagues in the private world. The more of you stayed than the rest of our group. But the other thing is, for Ron's sake, when you say mission health in this community, you get a few tweaks from people because there was an experiment a few years back that didn't go so well. But the deal was we were way ahead of our time. And so anyway, this volume to value thing, we didn't quite have all the way down. But mission health brings a different kind of a message to some of us. But anyway, thank you for sharing your expertise. In terms of things to be proud of, that is so hard to narrow down to two things. But let me do a couple of things about that. One is we've been in the hospital world have been on what we've described as the journey to zero, and I think that I don't have any graphs for you like Ron did, but we have seen tremendous progress due to looking at systems, looking at how we do things and creating greater teamwork. So some of those graphs are pretty astounding. Our bloodstream infection rate, for example, has gone up about 68%. So a lot of some similar kinds of graphs that we saw today. So the work that's being done in that space, I think, is really very, very laudable, but shared by the people at this table. I think the concentration on that, I know Dr. Perry's work has been great at St. V's as well, and really throughout the table. The second thing, though, I think I might mention is that we are seeing ourselves less as a hospital-centric system and more as a health system. And so, for example, in our primary care network, we now have 24 patient-centered medical homes. By the end of the year, we anticipate that will be all of them. And so we're very proud of that. We also have a division of our organization called Transitional Care that's looking at the patient not only in the hospital setting but beyond, as Michael kind of referenced in his conversation. So that too is a different kind of look than we've seen historically, and I'm very proud that we're in that mode of looking from a patient standpoint all the way through their episode of care and beyond, taking care of them at the primary care level as well.
I'm Tim DeVlantis. I'm Patient Safety Officer and Chair of Quality at Mayo Clinic. And our biggest activity, I'd say, for the last almost 2 years is we've actually contracted. Mayo, has a site here in Rochester, in Arizona, and also a health system up in the Midwest. And as an enterprise, we contracted with Dr. Leonard and his group at Pascal Metrics to introduce the team-based engagement model that he touched on in his slides. And this is happening enterprise-wide, all across Mayo. All 50,000 employees at Mayo are going through this team-based engagement, and that's a huge activity. You know, my little piece here in Jacksonville is to bring the Florida operation through this process. And it's really been a real eye-opener. I mean, at Mayo, we pride ourselves with knowing the science pretty well. But again, it's the cultural changes that everybody faces. The cultural barriers, we have them just like everybody else does. So it's really eye-opening when we get the surveys, and we do the surveys with the units. We've identified about 100 different ways to slice the clinic into units. They get a survey, they answer those questions, some of which he showed us, and then as facilitators, we look at these surveys, and it's eye-opening. And then we have focus groups, and we actually sit down with the employees in the unit, and we sit with all the nurses, we sit with all the care techs, we sit with the different groups as separate groups. And kind of probe and ask the questions, how is it that this is, the way things came out in the survey? We ask open-ended questions like, what's the stone in your shoe? What's that little thing that bothers you every day? What do you hate when you come in the morning? And one of the responses was looking in the parking lot and see whose car is here. And just try to peel back the layers of the onion to find out what's going on. Then everyone comes together for a didactic session talking about the basics around team-based engagement. And again, it's really eye-opening to find out how people really don't function as teams, many units. A lot of them, they're in the same work unit but never talk to each other. Does that ever happen? But it just really is amazing. So we bring them into these sessions. We have them develop aim statements, which is, come up with a cultural aim statement, how are you going to change, what do you want to change and by when? And one of the examples that came out, one of the first units was we have the patient care technicians, which is like the nurses' aides and the nurses on a hospital unit, and they never talk to each other. And it came out in the focus groups, and so one of their aim statements was, well, we're going to round together. And it seems kind of basic and kind of simple, but it was a real challenge to get the nurses, and because the nurses thought that they were above the PCTs thought the nurses never want to listen to us. And anyway, you work through that, and it just starts to permeate the unit, and that's how you change the cultures. So we're still going through that. We've been probably 16 units now, and we're rolling it out. And the nice thing about it is as you go, people have started to hear about it. The first 3 units, it was totally new to everybody. Now we've done a couple of surgery units, and so there's some crossover in the surgery area. So as you go to the next unit, well, they heard about it because their colleague in orthopedics was doing it. So slowly it's starting to infiltrate, and we'll see what the data shows. One of the goals is after a unit has been through the process, we go back and resurvey them a year later. And we're just now starting to get some of those surveys back to see if we've moved the needle at all. But it's real eye-opening.
Great. First, I want to say thanks to Dr. Paulus for that great presentation. I'm Phil Perry. I'm the Chief Medical Officer from St. Vincent's Healthcare in Jacksonville here. And we're part of Ascension Health, which has currently 69 acute care hospitals in our system. So from a national point of view, how do we address these issues? We're part of one of the hospital engagement networks, which is the Partnership for Patients with CMS. And that looks at the system and our goal of 40% reduction of the measures of harm, hospital-acquired conditions. There's 10 measures that are in that program. And a 40% reduction by 2014 is a pretty lofty goal for some of those measures. Difficult, but not impossible. So the whole organization is trying to drive towards that 40% reduction. We've made some progress as an organization, and we're always following our performance, trying to get to that 40% number. But some of the success stories, 17 of the hospitals are at 0 rates of CLASB, 24 are at 0 rates of VAP, 39 are performing high levels in obstetrics, which is eliminating early elective deliveries and brachial plexus injuries. But overall, we're not at the 40% goal yet, so we still have a lot of work to do. Until we're at 0 for all of these measures, we haven't achieved our goal. Locally, 4 or 5 years ago, Ascension started training all of the organization, all of the associates, 110,000 of us, plus many tens of thousands of providers, in the science of high reliability, with the goal of eliminating serious safety events and preventable injury to patients. Now, we've made a lot of progress on that, and our individual hospital have reduced our rates by over 60%. And serious safety events, for those of you who aren't familiar with that, are serious, permanent, or temporary harm to patients up into including death. Every day, each of our hospitals has a safety huddle. Ours is at 8:40, at 8 o'clock at the Southside Hospital. And the first thing we do is talk about how many days since our last serious safety event. Then we look at the last number of days since there was an associate injury, then how many days since a contract employee injury. And then we talk about good catches. And we know that it's very important to improve people's performance. We have to give good stories too, that we want to reward people for doing the right thing. And we want to do that in kind of a 5-to-1 ratio, but it's 5 good things for every time you talk to someone about something they could improve. So we talk about good catches first. And then we talk about what we need to be aware of in the next 24 to 48 hours that could affect patient outcomes. So for example, if a lab system's going to be down, or if we're going to have a downtime in phones, et cetera, et cetera. And then we talk about what happened in the last 24 hours everyone needs to be aware of. And we also talk about patient satisfaction issues that have been raised. And we do this on a daily basis, and this helps drive the culture of safety. This huddle includes clinicians and non-clinicians, so literally any issue involving operations or clinical or non-clinical in the hospital, there's someone at that meeting every day that can get the problem fixed, or at least tag a name to it and get it on a list that we can get it fixed. So that's been really instrumental in driving the culture change.
Okay, so, no, thank you all. So let me give you a couple kind of thoughts or reflections, and then certainly invite Ron to do this. I mean, I think what's wonderful is you're all able to articulate very specific messages and very specific aims within your organizations. And I think one of the real challenges is how you do this work and how you sustain it, right? And you know, what I loved was every day we get together and we talk about this and we reinforce these are the basic aspects of our culture and here's what we're driving to. And I love the 5 positive for 1 cup of coffee or 1 shot of tequila, or maybe, I'm not quite sure who's taking the shot of tequila, but we'll discuss that later apparently. So let me give you a couple of thoughts that come to mind here. I think one of the areas we have unbelievable opportunity is in transitional care. And what I'm talking about, so 10 years ago when I was working nationally for Kaiser, I was working in Southern California, and we actually looked. We went from 1 hospital to 1 skilled nursing facility, and they asked the question, what percentage of the time do these human beings show up and have their pain medicine, their antibiotics, their psychotropics, and their anticoagulants? And the answer was appalling. It was 11% of the time. They had all 4. And then you could put in some structural pieces. We have a single ambulance contract with AMR nationally, so when do they go? They go in the middle of the night when nobody's there and nobody knows them. And so they put in a simple checklist. Nurse in the hospital has to talk to nurse in the SNF, reconcile pre-5 p.m. or they don't go. They cannot leave the hospital. The next measurement was basically above 90%. And the other thing they approached was they're very good at code status, but they're never really good at preferred intensity of care. Under what conditions does this human being want to come back to the hospital, which is usually Saturday night. They have a problem, nobody knows them, we ship them. And nobody wanted this. Somebody was demented, the family get the phone call, they're in the ICU intubated, what nobody wanted. And they were able to avoid one unwanted readmission to the hospital per week in a population of 300,000. So never underestimate the ability to do simple things well. Let me also speak to your comment on serious safety events. Actually, folks at Healthcare Performance Improvement are good friends of mine, and I'm an admirer of their work. I think we want to cast the net broadly, and we want to act narrowly. And I think, and obviously the serious safety events are above the water, and when we get good at analyzing those through common cause analysis and acting on them, one is we create huge value, and two, we lay the foundation for digging deeper into the iceberg. I'll give you a simple example from the Kaiser world. I'm actually quite interested in obstetrical safety. And they in Northern California now, any APGAR less than 7 at 5 minutes gets a formal analysis. And not who made a mistake, who screwed up, but how did we get to a place we never wanted to be? And they are required to share that learning among 17 other hospitals. They have reduced the number of low APGARs almost 50% over the last year. Because by saying we ended up somewhere we really didn't want to be, APGAR less than 7 at 5 minutes, term baby admitted to the NICU, you look back upstream and say, what are the decisions we made? What are the things we did? Whether we hyperstimulated, I guess I can't say that anymore, it's supposed to be tachysystole, sounds better, but baby's not in good shape, nothing sounds better. But that ability to look at hard signal significant events and work backwards, I think is very, very valuable. And the ability to demonstrate and just continually message that, and particularly the kind of data Ron showed, that's what makes us sustainable. I would also say, in my experience, the ability to come in and say, here are the deep behaviors that create value, here are the behaviors that create risk that we are not going to engage in. Let's codify them through teamwork and the way, formalize and habituate the way we talk to each other every day, and then the what's in it for me. That debrief, that capture, that ability to change something is what really kind of creates a sustainable virtuous cycle.
I admire dramatically how you've come together to collaborate. And the idea of care transitions and that collaboration opportunity, you all went through a nice iteration of, the things that are working. If you don't mind, I'd like to put you on the spot a little bit and ask, what are the areas that are not working? Maybe just pick one. And what are the opportunities or enablers that having a peer network like this one, where you really can collaborate and really share, information back and forth, what are the latent opportunities that might enable you all to grab onto those things that you're struggling with now? Maybe we'll start at the other end just for fairness and being put on the spot.
Well, I think we constantly struggle with maintaining or achieving a environment where people feel safe to let everyone know what their issues are. We have challenges with medical staff staying engaged. The hardest part of our process improvement is sustainability. So they've been trained, but they slip, and it's difficult to find the resources to retrain physicians. So we're going to talk about requiring it, recredentialing, at least for a web-based thing. Sustainability is really difficult with particularly with the amount of turnover that we have with our staff as well. So if you have 15 or 20% turnover, that's a lot of new people that haven't been trained. So that's not working well.
If you're talking about challenges, and particularly at a community level, I look at handoffs and patients, leaving the hospital, going to another facility. Oftentimes going to a nursing home or skilled facility, and oftentimes, as I still do inpatient work, and it just seems like it's a black hole sometimes. When you discharge someone, we at Mayo cover one nursing home, so if they go there, I know what's going to happen. But otherwise, if they go just about any place else in town, I fill out the little pink sheet and hope that it happens, and that's the last I know. So, if there was any place where we could do something on a community level, it would be to try and improve the communication at handoff and when patients go to a step-down facility.
I think the theme for today really has been around, a lot around communication and teamwork leading to effectiveness. You got to have systems in place, but you can have all the systems in the world, and if people aren't communicating, you fall short. And so I think for us, with the kind of medical staff that we have, it is the communication between the team members, if you will, who don't necessarily see themselves as a team at times. They have their part, and then they pass it off to somebody else. And so I think that from the patient's perspective, it feels fragmented and not cohesive. And so I think that that's one of the biggest challenges we have as an organization, is trying to affect that. And I think people have really good intentions, but it doesn't necessarily carry it into practice at times. And for us, we have a hospitalist program, and they're to be the glue. And some of them understand that and do it very well, and some don't. In terms of how we fix that, if you've got an answer to that, I'm available right after this, because it's a huge challenge. But I think that in every space, the interdisciplinary communication and teamwork is where continued work has to be done. And in terms of how I would agree with Tim about sort of the transitional things. So care being not only within our intra-organizationally, but throughout the community, better and perhaps more standardized ways to communicate what's happened and with this patient and what the situation is, so that there is direct contact, would make a big difference.
I think one of the biggest challenges that we have is just the military culture in general, because as it was mentioned this morning, not only, do you have people that sometimes are afraid to come forward just because, they're dealing with a physician, but we have the rank structure. And so we have to continually work, to try to ensure that it's okay, even though we're in the military, that if you see something wrong, you've got to come forward, and you've got to be able to say, hey, something's not right here. And also, it's that sustainability piece. We have to continually train our folks on the Team Steps concept. I think that's one of the ways that within the facility we do handoffs very well, because we have the entire team that meets from the most junior person, on up the chain. And so we can discuss, okay, what's going well, what is this patient going to need, and that type of thing. But it's again, that sustainability piece. And we have to be able to lead from the front. I can't tell my staff that they need to go do Team Steps training or caring communication if I haven't been through that myself. And so one of the first things we did was the entire board of directors went and did caring communication. And, we have to lead from the front, and I think that's just one of our, main emphasis in trying to ensure that with our turnover, we just have to continue to train our folks.
So I'm going to take a slightly different route to this, answer your question. Since I'm not a hospital administrator, I'm an infectious disease doc. I think you asked what's our challenge. I have a privilege of working at 2 health systems. I think one of the biggest challenges, and I would suspect everybody else on this, is improved hand hygiene. Being an infectious disease doctor, and the top 6 of the top 10 IOM things that are related to infectious diseases, I think more important than any of those things, those are the simple thing is the hand hygiene. So I think that's a huge, huge challenge. In terms of the community level, I think what we need here and what we are lacking is, as you know, we don't only hand off patients, we hand off their bugs also. And we don't have a strong antibiotic stewardship program at the institutions, hospitals in this town, and more importantly, a community-based antimicrobial stewardship program. We have a huge problem with MRSA and other things. So I think that's something that we could certainly work as a community, because we have the infrastructure, if you will, which you see around here, to make that work. As many of you are aware of studies from Orange County, that what happens in hospital A is going to get to hospital B and then to C. So I think that's a community level impact that would be quick. And last but not least is establishing a very strong community level, hospital agreed, highest level of immunization against influenza required for all healthcare providers. So those are things that, again, we will not hand off influenza either if we immunize all our healthcare workers, because I think those are the sorts of things I think that could have a significant impact in the outcomes for our community, not just the one hospital, one patient.
And if I could just make one comment there. I think that's a great idea. And it seems like it's totally doable. I mean, creating one antibiotic stewardship program is as easy as creating one for the whole region. And, so I think that's an absolutely spectacular idea. And if there's a receptor for the antibody, I think it's worthwhile.
So the question on, what are a couple things that, could be going better? And, for us, the first two things that come to my mind are, we are a collection of discretely very different businesses. Skilled nursing is very different than home care versus inpatient versus outpatient. And each one of those lies within their own regulatory environment, competitive environment, workforce issues that can be very unique in some of the post-acute settings. And so the two challenges I think that first come to mind are how to keep the discipline within our organization to focus on the vital few changes and initiatives we have, because every one of those businesses has their own need to change and adapt. But if everyone does it on their own, you kind of create a little bit of chaos. So one is maintaining that discipline to say, what are the vital few things we need to stay focused on, and keeping focused on that. And the second really is how to bring about sustained system change across those different lines of business when those businesses, each business is very unique, the patient profile is very unique. There are some very unique workforce issues within those different sort of settings. You go all the way from, let's say, inpatient rehabilitation, which is a hospital, and so you have all the benefits of being in a hospital, all the way out to home care where you have autonomous workers in social settings that none of us would ever want to be in. And so how do you bring about the level of change and quality and patient experience and engagement across all of those settings would be the second major challenge that comes to my mind.
Excellent list. My only additional comment, this is something I always wanted to do. We started it when I was at Geisinger. If I had a community like this, I would give it serious consideration, which links to your, Michael, your comment about the nurse handoff if you could conceivably define what you could call a discharge synopsis. So it's not the whole discharge summary, but it's the minimally essential elements that would be absolutely required for a patient to be discharged. Everybody had it. They had it in writing and they had it, electronically, so that nobody in the community would have somebody else showing up in that window period between the time the discharge summary was dictated and transcribed and, so forth and so on. I would just, always been on my list, and I just throw it out as an idea.
Yeah, and I mean, I think, I was at a Michigan Hospital Association meeting about a year ago. I'm a big fan of Sam Watson, who's driven the MHA work. And they have amazing data and amazing collaboration across the state of Michigan, because they will clearly tell you if we don't fix healthcare, Michigan is economically unsustainable, right? And particularly given the challenges the auto industry's had. And they're working on readmissions, and what was really striking to me was there was an acute spike in readmissions within 48 hours of going home, which means either you weren't ready to go home, you didn't know what to do, or you didn't know who to call, right? And so to Ron's point, I mean, how can you structure that you actually have a handoff, that the patient understands? And in fact, when you were talking about numeracy and whether it's 10% or 1 in 10, I mean, think that the average American reads at a 5th grade level, right? So they will sit there and nod their head all day long, and 50% of them at least will have no idea what you just said to them. And so that ability to do a quick teach back of, you've heard us talk about this, please take a minute and tell me how you're going to explain it to your family is actually quite valuable. So I think that piece is absolutely key. I think the engagement piece, and let me kind of ask any one of you, one of the fundamental challenges we see over and over is engagement and defining behaviors. And I'll give you kind of a simple example. I know from personal experience when we look at low safety culture units that the compliance with hand hygiene, the compliance with very basic things, the things that cause people to get MRSA, which are life-changing events, go up. Because not only am I not going to hold you accountable, but I'm not going to hold myself accountable because I'm just trying to get through the day and the culture says it's okay to kind of cut corners and slip. So what was really fascinating to me was about 4 or 5 years ago, I worked with IHI on the work in the United Kingdom around safety and quality. And I was in a hospital in Scotland, in Forth Valley, north of Edinburgh, and I'm standing in the hallway. I mean, they have pretty close to 99% hand hygiene. And they have soap, and they have signs on the floor and on the walls, et cetera, kind of like we do. And their whole policy is naked below the elbow. You go see a patient, no jewelry, no clothing, wash your hands. And I'm standing talking to a friend in the hallway, and an orthopedic surgeon in a 3-piece suit starts to run into the patient's room. And without missing a beat, this guy just turned to him and said, "Fred, I certainly hope you're not going to see my patient dressed like that." I mean, just pretty casually. And the guy just like stopped and shook, took his coat off, his jewelry, his watch, washed his hands. And I said, "Is that inherent in your culture?" And he said, "No, but we believe, we know we cannot fix that problem without that mutual accountability." Now what's interesting is you go into a hospital or anywhere in healthcare and say, "Should you wash your hands?" Very few people are going to say no. But if you ask them, "Okay, now you're responsible for washing your hands, are you responsible for me to wash my hands?" And the answer is no. So I think until we create what I call, for probably lack of a better term, that's citizenship. And I think it also extends to how do we engage the docs? How do we, because I think the hallmark of excellence in any organization is one set of rules. And I can't be in a hospital where the nurses and the residents have explicit requirements around ACLS or certification and fetal heart rate monitoring, and it doesn't extend to the doctors, right? Because that sends a message very quickly, you're different, you're special, you don't have to play by the rules. And I'm not going to pretend it's simple, but I will say that very high-performing organizations say you are a citizen in this community. In order to create value for yourself, the people we take care of in the organization, you're going to do simple things. And I think, I had the privilege of being with Gary Kaplan in a meeting in England about a year ago for a couple days. And we were talking about, Virginia Mason said, if you don't get a flu shot, you're not working here. And they got sued by the nursing union, and they just completely refused to capitulate. And the trade-off was if you don't get one, you wear a mask around, right? And they made them wear masks. And I think they were high 90s, 96, 97%. And then they had some people walking around wearing masks. But they just said, it applies to everybody. It's in the interest of the patient. There's no logical argument against it. And if you're going to be here, you're going to do it. And so we see examples where that happens. And there are environments where we can kind of tell people what to do. I was smiling earlier when somebody says, well, if you're an integrated system and you employ the doctors like Kaiser, yeah, I was like, that's step one of the 12-step program, right? You can get them in the room and have the conversation, and anything beyond that is, hard work. But I think that's a really important piece of how do we create that culture? And the other thing I would say, and then I'll kind of stop here, was I think it's critically important to enculturate people from the minute they walk in the door, to say, this is who we are, this is how we play, this is how you'll be successful, and don't do this, right? And I'll give you a simple example from Missouri Baptist and the Barnes system. I was there some time ago, and I was talking to Carm Mosseri, who's the CEO, who's an ex-ICU nurse, day one of new employee orientation. And he says, it's about 4:30, I got to go down and say hi to the new employees, and why don't you tag along? Sure. He walks in there and he says, I'm delighted you guys are here. Well, let me take a few minutes and tell you how it works here. And he finishes, and he said, if that works for you, I'll be glad to see you tomorrow morning. If it doesn't, don't come back, right? I mean, it was very simple. Day one, here's how we treat each other, treat our patients. This is our mission. If that works for you, glad to have you on the bus. If it doesn't, let's not, shall we say, extend the pain here. So, other thoughts?
Thoughts for the day, from the day, you mean?
Or any thoughts?
I think my biggest takeaway from the day is, I think we all know this, there's no silver bullet, that's for sure. And everything goes back to, or almost everything goes back to human behavior and understanding what drives people, and kind of starting there and working outward. And that it's, like we know, a lot of hard work and a lot of blocking and tackling.
So let me give you one quick comment. So, I think you do have unique opportunity. I would say one of the few places, aside from this, that I've seen a collaborative environment among competing health systems is Twin Cities, Minneapolis, St. Paul. And through ICSI, the Institute for Clinical Systems Improvement, over the last 15, 20 years, they've had all the systems in the room, Mayo, Fairview, Park Nicollet, et cetera. I did a surgical collaborative with them some years ago. And I'll tell you what was striking to me. It was around surgical safety, and the guys from Park Nicollet, who had gotten lots of press for taking the wrong kidney out of a patient, took out the normal kidney, not the cancerous one, which actually turned out the patient had come in with terrible cardiac problems, had an aortic valve, had a very stormy course. The mass was found, was seen 11 times by the urologist, and in one visit, he accidentally wrote right then left. And from that time on, it was the wrong side. And they actually came in the room, they had the imaging, they didn't put it up, and they took the wrong thing out. So you think about the candor of those people to get in a room with surgeons from competing institutions and saying, let me tell you how we did this. And I remember Claude Deschamps, the chair of surgery at Mayo, wonderful guy, who got up and said, I can't thank you enough for telling us how you did that, because we couldn't figure it out. And now that we know, we can figure it out, right? So, like the aviation industry, if you go to their meetings, they're brutally competitive, but they don't compete on safety. And they all get in the room and they say, let me tell you what we almost did, and let me tell you what we can learn from it. And I think that's a unique opportunity when you basically create a safe space to say, here are our challenges, here are our near miss, here are the things we really do not want to see happen. You can derive tremendous value for your community.
Both of you have noted, and you're not the first to do so, about the collaborative nature of the healthcare community here, and I think that is true. And I would just move on to say, not only of safety in the airlines, but probably the nature, the spirit of this conference over the years has been, we ought not compete on quality. We ought to all be striving to raise the level of quality throughout the community. And we can compete on other things, but quality ought to be something that is a shared responsibility.
I was going to just mention, several years ago, I heard, about a couple of decades ago, I heard one of those lectures where it said 2 decisions are always executive decision, parking space and office space. I think same sort of thing should apply to healthcare system. Yes, we are trying to change cultures, but as I think you alluded to that, certain decisions are that this is how we do it. At Intel, if you don't follow the process while going into the factory, one time you get a warning, second time you get fired.
Sure.
And that's we're talking about a chip. And we give our physicians and other healthcare, there's so many times opportunities, we do the progressive counseling, and then oral counseling, and then written counseling. And one of the things I think which happens with that culture is things just keep rolling on without anybody seeing. I'm not just talking about a punitive being the only thing we do, but on the other hand, certain things you have to say, we are not going to stand for that. I think that's what you were alluding to, but I think we are so much into, a lot of democratic things, and some things have to be autocratic.
Yeah.
And this is what's going to happen whether you like it or not.
Any final comments? I think our time is just about up. I want to, with Michael, thank the panel for what they're doing, and give you guys a comment. I was on a panel recently with Bob Berenson, and he observed that sitting is the new smoking. So your smoke break's almost over. There's just a little bit left in the program. But thanks to the panel.
Yeah, thank you.
Stay?
Yeah.
I think we're supposed to stay. Sorry, I didn't know that. Yeah.
And Phil, could you, Captain? We've had a little bit of a change in plan because we know that some people need to get home and are tired, but we did need a little more information, which could really help us. So instead of having a breakout quality steering committee, we're going to have it right now, quickly, and we appreciate very much your staying here. And Phil Perry, didn't I give you an option?
This is like a volunteerism.
Well, we had a majority vote with the Navy, I think. Phil Perry had brought up that he would appreciate the council getting some input to each other, and of course this is even better, about the immunization policy. Number one, Phil, you could, I think, address it better than I, because you've really...
Thank you, Yank. Many of you know that there are some states that mandate vaccination. There are some cities where all the hospitals have cooperated and have mandatory vaccination. Last year at our hospital, we instituted mandatory vaccination for all of our employees and got over 99% vaccination rate. Two exceptions, true medical contraindications, which had to be substantiated by a physician, or a religious exception. And otherwise, we gave people that didn't meet either of those two qualifications, they had to wear a mask from, I think, January through May. This policy was difficult to extend to the medical staffs, and there were a lot of questions from our associates. Why are the doctors not being forced to do this if we're being forced? Now, our medical executive committee did agree to mandatory vaccination, but we had no way to measure and no way to enforce that. With the news out about the Middle Eastern SARS-like virus and about a 50% mortality, I kind of think we're on the threshold of a practice run for something that could be extremely deadly. We don't know when that next killer virus is going to be out there. If there was a vaccination for that SARS virus and we knew that people were starting to be infected in this town, we would make mandatory vaccination for all healthcare workers mandatory by tonight. So why are we not doing that now to protect our patients from influenza and pneumococcal diseases that kill our elderly? But we're not willing to do it. So that's the question that I want to raise. The community chief resource officers met and came up with a prospective plan, which they've shared with the CEOs. I don't have the exact details, but it goes something like agree to get to a 90% vaccination rate in this upcoming year, and then over the next 2 years progressively move up towards 100%, with a plan that we can agree on from the medical staff to include the medical staff along with that progressive increase moving towards the goal of mandatory vaccination. So I'm bringing that to this group to elicit support from the physician leaders as well. We've got it from the chief resource officers. We know there are issues with unions and that the negotiations that have to occur there, but we also have issues with physicians where we can't measure very easily if they had a vaccination from an outside source or at another hospital, and we have to kind of take their word if they say they got it. So interested in what people think about that.
Phil, could you break this down maybe into 2 or 3 questions so that everyone would address the single question first and then rather than...
Well, one is the group agreeable to a progressive goal over the next 3 years to get to 100% mandatory vaccination?
Anyone want to address that?
So we at Brooks have started that conversation a couple weeks ago, and as an executive team, and the question mark came on, there is, like you mentioned, the religious exception and the verifiable medical, and I think the question mark came is there a personal declination? In other words, I just don't want it, and that counts as, let's call it, counts as a vaccination, counts as compliance, if you will.
Yeah.
And that was the question mark that came up is, why would we accept just a straight out personal declination as long as they signed, I don't want it, that would count as they were vaccinated. We met the goal, and because I think it comes back to what you said. We know it's good health for the patient to vaccinate, have everyone vaccinated. So shouldn't it be everyone? We have started that discussion, and I think that's where we got a little tangled around is that personal declination.
If I
It's
could
not only the
offer
patient,
something.
it's the staff as well.
I'm sorry?
You're protecting not only patients, but
Each
other
other.
staff as well. And the declination, I think is the way the policy works, is that you have to wear a mask. If you choose for whatever reason there may be, then that would be what you'd have to do at this point. So that's a pretty big disincentive, by the way.
I believe in our next iteration of this, the personal declination won't be an opportunity. Any new employee we hire now has to agree to have the vaccination, except for a medical or religious reason, and they will have to wear a mask if they meet one of those 2 qualifications, or we're just not going to hire them. And at some point, we just have to decide if you're not willing to do this because what we're about is taking care of patients, then maybe you shouldn't be working at our hospital.
I think what's important if that becomes the standard for this city, this region, then I think you have a better chance of standing up to any opposition by any group. Or I think if I understood you correctly, even if it's personal declination, they'll still wear the mask. The minute they enter the institution and the minute they leave, they can take it off once they leave the institution. And I think then you will have a small group of people who will stand out. And there'll be some peer pressure too also. And even if you have medical condition, you understand. And this has been looked at by others. They could not come up for influenza vaccine many reasons for religious exemptions, but there are some. The personal declination part is really, I think, we also need to educate the staff. In basically, none of us who would go to the hospital, take care of patient, would want to give a germ, come in with a bag full of germ and give it to our patients. It's the same thing. Final thing, I think, as a physician, I think you cannot say that the physicians are going to be excluded with any reason. If you cannot include the physicians as the first people getting in line to immunize, then it's effort, frankly, not worth doing.
Ron, you have a response?
Yeah, I just wanted to, for what it's worth, it's easy for me to say because I'm not here and I don't have to do it, but, we've done this at Mission already. I did it my first year as the CEO. I think the idea of I'm always subtle, I think the idea of a personal opt-out is idiotic. What if somebody wanted to opt out of aseptic technique? You're just like, okay, it's fine. The second thing, I would strongly encourage you, do it all at once. To do it slowly is going to perpetuate the pain. I got 10,000 emails the first year. I got 50 the second year. What we did, for what it's worth, is to say, date certain, you have to have it. It applies to everybody, the docs, the nurse, it doesn't matter. We don't give the mask option. You would know better, but at least what I was educated is the mask doesn't work. It's not effective. It's just sort of a scarlet letter thing. I don't see what the value of that is. We suspend people after the date certain, and then they have 2 weeks to, you're suspended. If you get it within the 2 weeks, at the end of the 2 weeks, you're terminated. And we had to terminate, what was it, 7 people the first year, and then I think 2 or 1 the second year. It just, and you have to understand, Asheville is like, the most anti-vaccine capital of the world. So this is not like we had it easy. We don't have a union, that's the only thing, so I don't know how that works, but I think doing it over multiple years is not a good idea.
Could you stand up, please? Thank you. Thank you. Thank you. Any other comments?
How did you deal with a rare person who truly should be medically excluded?
We had the same 2 exceptions. We had bona fide religious. One of the emails I got, my body is a temple, that one didn't fly. That's true, that's not a joke. And what do we have, is the ethics people do the religious thing, or I can't remember? But there's some process to get bona fide religious, and then there's you have to have an allergist, sign off on your, and they're very few. I mean, they're incredibly few.
Phil, does this help?
We had a mandatory at Mayo this year. It was for everybody, and the physicians all had to get it through employee health to document that they had it.
Straightforward.
For employed or physician organizations, it's relatively easy, but those organizations where the physicians are not employed, that's the one I think we still have to be very sure that we want all the physicians to get the immunization.
Any additional comments? Phil, do you have another point that you'd like to have a comment about?
Well, if we do ask medical staff leadership to support this citywide, how would we track, for example, if a physician at my hospital is vaccinated in our doctor's lounge and they also practice at Baptist, how would we effectively share that information?
Why can't the physician bring a note from wherever they got the shot? I mean, it's not just a card or something and say, the doctor signs it, I give you the shot. I mean, we do it for, God, so many other things. And, with the immunization rate for healthcare providers for 12%, I mean, it's almost shameful.
It is embarrassing to think that the physicians are following on this and not leading, though.
I think that's very helpful. Our committee will meet as soon as we can get the folks together. And if you have any other questions in the meantime, Phil will certainly bring them up.
Thank you.
Thank you all very much. The second question is related to the Care and Communication course. As you know, 7 institutions incorporating, I think, 11 or 12 hospitals now have faculty trained. Other institutions represented here who don't have faculty in their institution to deliver the course to their staff who would like to be included in the fall course. It may be that everyone here is in an institution that has it, so if you don't, then let us know, and we'll see. The next one will probably be in the fall. Some of you.
I did want to say that we're interested in us trying to get a second group trained at this point. It's with just 5 of us, and we're going to have a 3rd hospital and 1,200 medical staff. It's putting a little bit of a squeeze on our time.
Thank you. And we have done that in the past. The Navy has been in 2 or 3 courses, and the Moores has actually also been in 2. We have a tradition of trying to help out in increasing the number of faculty in the community. To do that, we need support, of course. Otherwise, it is a very expensive course to give for good reasons. Unfortunately, we've had the Arthur Vining Davis Foundation, the Riverside Hospital Foundation, Department of Defense. So you're all communicating to them that you think this is important when the subject comes up helps. They seem to be very receptive to continuing, but they, I think, have to be appreciated to really be persuaded without a lot more effort. The other area is that the collaborative is a pretty informal organization, but the Quality Steering Committee needs to probably think in the next meeting regarding some continuity. So any input from your institutions regarding this regional collaborative being formed on a little more formal basis. Some of us are getting almost close to retirement now, and so we want to make sure there is continuity of all these activities if it's felt to be needed. And so we'll start addressing that at our next meeting. But your input regarding whether it's valuable to have this collaborative Quality Steering Committee, and then we will move forward from there. But we greatly appreciate your input, and we want to particularly thank our panel. And we're back to patients again, because we're all going to be a patient sometime if we're not already. And I just wanted to remind us that's what we're all about. And the second thing is, Maya Angelou certainly summed it up very well, that people may not remember what we said or what we did, but they always remember how we make them feel. So it's something that we can know is a tangible benefit from what we're doing, and it makes us feel well as also. And then the physician philosopher says, it's the common need of humankind to be useful, and we are certainly blessed with the opportunity in our professions to be useful. So it's a nice day to count our blessings and the opportunity to live in this country and do what we're doing. Thank you all for contributing so much, and especially our keynoters and our panelists. Thank you very much.